what you're going to hear about is clinical application of mechanical biology, which is what everyone's been talking about. So what I've done is, when I turn this around the right way, is just put together a bunch of cases to show how I look at it. So again, I've excluded where you got bone loss and where you've got obvious infection, because I don't think that's a simple non-unit. It's a different league of problem that you have there. So if you have a big bone gap, then you need to do something different to accommodate that. So this is the two legs of one unfortunate man, and the left leg was open in the femur as well as in the tibia, and the right leg was open just around the tibia. He subsequently had a left leg amputation above knee, and this was put on over his open fracture. This is quite a long time ago that this was dealt with. And he went on and poodled on, and I saw him subsequently when he had his frame removed, and he had that non-union at his tibial site. You could see that when he put his foot down, it bent, and when he took his foot up again, it looked a bit better. So how do you address that issue? And so there's lots of ways that you think, well, I need to get the mechanical alignment right, I need to make sure it's stable, and then it should heal. But at that first picture that I had about when you're making decisions, there was a person was the first line. What's the person like? What are they? And he's now a one-legged man who'd had a pretty sorry episode on his other leg. And so of all the interventions that you might think of there, you didn't want one that was going to give him risk of losing that leg as well. You wanted to make sure that the percentage was very low. So this would please Alex, Alex, London Alex, all wires on that frame, and just held it in a straight line. Did you need to work out any angles? No. If you're a simple fracture surgeon like myself, what you do is you put your knee on the leg until you push it straight, and then you put the frame on it while it's straight, and it saves a lot of computation if it's at the one level. And he went on, good alignment, satisfactory, nice, straightforward, deal with the mechanics. This chap, he came back, this was we get skiing patients come back each beginning of each year, and they've been fixed elsewhere, and they come back full of enthusiasm. And he had his humerus fixed, presented with that. Well, it didn't look too good, but it was sort of managing. And then a few weeks later, he came back, and it was broken. So he's got a non-union. There's no question that we need to deal with that at some stage. I don't think that that's going to unite on its own. You can treat humerus shaft fractures without operation, but at that level, you're going to do something about it. So how are you going to manage that? How are you going to manage that patient and their particular circumstance? Well, the scary thing about going in to deal with something about that is getting that out without damaging the radial nerve, and putting something else in without damaging the radial nerve. And you look at that and think that was actually trying to heal. That was a delayed union, but it was delayed long enough for the metal wear to fail. So I'm not unhappy about putting in the same sort of implant at a second occasion. So one of our colleagues who works in Swansea, Ian Pallister, has this nice adage that you should always go into an operation with various plans and along the pathway with various plans. You have plan A and then plan B. And one of the adages at the bottom is that plan B shouldn't be the same as plan A. If it's already gone wrong once, then, but when it's got that close, you think there's a fair chance. So with him, carefully remove the plate, and you see that the wave plate construction on there, you're trying to preserve as much of the bone healing organ as you can around there. There is no need to take down a fracture site. Very, very seldom will take down any sort of fracture site unless you believe there's a pseudoarthrosis. There's a bone healing organ in there and you need to preserve it. But you don't need to preserve it to the extent of damaging the radial nerve. So I removed the channel to sit the plate so that the plate did not come above the original line of that bone healing organ, of the forming callus in there. So the radial nerve was no more displaced after that went in than it was beforehand. So you'd addressed the mechanics, you'd protected the patient, and you've hopefully, and he united. Couldn't find the poxy little bit of wire that was in there that they put in at the beginning, but I wasn't going to damage my bone healing organ to look at that. So this has not gone as well as it might have done, as you can see. He was in his early 20s, and he'd had a relatively high energy femoral neck fracture, which had been fixed. And when you can see that it's subsided somewhat, and the CT scan on the right shows that he has a plane of non-union. So where does the mechanics come into dealing with that? Now, all along, people have been talking about shear and how shear is a bad thing. And something that I didn't notice till the other day, but you can, as long as you don't have nail varnish, you can do on yourself, and you can show how shear affects blood supply. So if you look at your thumbnail, and hopefully there's some pinkness underneath the thumbnail. So look at your thumbnail, look at your thumbnail. And if you press it with the tip of another finger, you can make it blanch. You can make it go a little whiter underneath, just under that area that you're pressing. Now, if you look at your thumbnail and get to the end of the nail and push hard on the end of the nail, so try and shear the nail across its nail bed, the whole nail bed goes white. So when you get a localized force, you get an area where you're potentially compromising the blood flow. When you get a shear force across that plane, the whole area can lose its blood supply. So shear can be bad mechanically because it can occur because of its orientation. Shear can occur because of the orientation of the residual line in relation to the load bearing, and shear is damaging to the angiogenesis, which is in that area, because as you can see, it can damage the whole blood supply rather than a proportion of it. And if you remember a slide that Alex showed at the beginning of strain when you bend, if you bend, the damage and the strain is going to be limited to a small area. As you shear, it's the same all the way across. So how do we deal with that? And the customary way is it's one of the few times I actually end up measuring angles, is that you reorientate the fracture line. And so you reorientate the fracture line by doing a valgus osteotomy. And you can see what we've done there, worked out what we're going to do. I still do it the old-fashioned way. I'll draw it out on pieces of paper, cut them up and move them around and make sure I can make it look like the other side. And then fix it with a blade plate, and you get more or less the same shape as you have on the other side. And of interest there, you can see a couple of concepts in how you're trying to get the fracture to unite. So in that area where there's a void, and we've brought it into contact here, that is, you're hoping for direct bone healing there. The blade plate is a huge spring. And as you insert it, you can either put it in with it standing off like we had with a slightly pre-contoured plate, that as you hammer it, it tensions itself, or you can put the compression device at the bottom of the plate and pull it down. But you store a lot of energy in that blade plate, and it's a big spring, it will save it there, and they nearly always unite quite rapidly when you've got that compression across a blade plate. The original non-union, you can see the fracture line is reorientated, so it's now much better aligned to the joint reaction force that there's going to be there and where the weight bearing is going to be. There's no way that that's absolutely stable construct across that line, but again, experience of these is that they tend to heal well once you've reorientated it. And he went on, you can see how he filled in all the gaps around there. Similarly, you try and avoid damaging the soft tissues on the medial side. So that's a reorientation of the fracture line to get the bone union. This is an example of when plan A hasn't worked, resort to plan B, make sure plan B isn't the same as plan A. So this lady came back, she'd been skiing in France as well. She'd had a fracture of her proximal femur, she was in her 50s. She had it nailed while she was away. She lived between France and England, and this was the second nail that she'd had in. She'd had it revised because she had a non-union. So I saw her, and it's a tip to apex distance is a bit close, but we thought we would wait because it didn't look too bad, but we waited, and she came back a couple of weeks later, and this had happened. So certainly if plan B hasn't worked and it was the same as plan A, you're not going to do the same thing again. So blade plates cure everything. This is what if you go on enough AO courses, blade plates are always what they resolve down to at the end. So this is a blade plate. This was done a little while ago when we had access to BMP. And so there's BMP there, there's God knows what there. Everything was thrown into this lady. And what more could I do? It was clearly going to work. So she it didn't look quite right. You just see that hint there of it not looking right. And she carried on like that. There you are. You can see it better now. And she stayed like, and it stayed like that, and it stayed like that I thought it's got to unite eventually. It stayed like that for about a year. And so we'd had plan A, we'd had plan B, and so plan C, if you want to stop shear, and you've got a mature fracture line like that, then you just need something else to go across that fracture line. So if you imagine, is this open? Yeah, so this door hasn't fully healed yet. Somebody's put it up, it's fixed in various ways, but it still moves. Now, if I want that door to heal absolutely, what do? Do I knock the bloody hinges off, take out the frame around it and start again? Or do I put a little wedge underneath or just turn the lock in it? And quite often, when you get a fracture plane which is there with intact metalware, what it's indicating is that the metalware is doing everything but controlling that one plane which is important. So don't remove what you've already got there, just add something to it, like the lock on the door, and you can do a minimal fixation and get a very big effect from it. And so that's her with putting a couple of screws across it, and she went on and united, and she's been 4 years without a union from her original fracture of 2 nails and the blade plate. So it was waiting for an appropriate mechanical environment. And when you provided it, it went on and did the job. And I've shown you that one before. So indications for doing something minimal, when you believe that you need to do something, when the overall position is satisfactory, both clinically and radiologically, when there's no overt infection and the fracture planes and pre-existing fixation are amenable to the placement of screws. Then what things do you need to be careful of? Don't miss the bloody fragments. It's surprising, you know, when people have got CTs post fixations in various areas, particularly around the foot, you put syndesmosis screws in, you find that you haven't put the screws where you expect. So a couple that we've seen not work, when you get a CT of them afterwards, it's because you never had them in the right fragments. They can be very hard to put the screws in, so drill, then tap, and be prepared to swap your drills out, because you don't want to burn things when you're going in. I don't think lagging's necessary. And the other thing then is, if you're trying to reduce the strain, as somebody mentioned before about with the acute fracture, do you change the patient's behavior? Then I would say yes. Now, whether that's absolutely necessary or not, I don't know. But what I do is I ask people to go back onto crutches for another 6 weeks. I can't see the point in pushing your luck at that point. You'd like an intervention which is straight, so I reduce the load. And as an example of where I didn't do it quite as well as I'd hoped, this was a man, he'd had a high energy femoral fracture. He looked like he was uniting. You could see at the time he had some screws put in, he was developing callus, and it just didn't join. What's 5 plus 2? Do you sample? Are you worried about infection? Now, we have a mantra that originated in Oxford at the bone infection unit, that if you sample, you always take 5 specimens for microbiology, each with a clean set of instruments, and you take 2 specimens for histology. If you can't do that, then I don't sample. So if I've just made 2 holes for screws, then I don't sample. I don't make the wound bigger to sample. But if you make a big enough wound to sample, then I do it and treat it as if it could be infected until we get the results back. So this man, when when I spoke to him a bit more, I should have spoken to him a bit more in the first place, but I learned that what he was doing, he was working really hard with a physio, and he was doing squat thrusts and goodness knows what to get fit because he believed that he needed to be fit to heal. And so to get stabilization around that fracture site, we did what others have suggested. So Chris Moran had published on that you put a supplementary plate on there. And at that time you can sample. So that gives you a greater stability in that area, still left the original implant in there, tried not to disturb that fracture healing organ, and then he went on quite rapidly and healed. And that was with the assistance of his physio not doing as much work for him. So I don't know what was the most important, but it worked. This is slightly different. This is something that hasn't united. It doesn't project very well, so I'll tell you what's there. That's an international weightlifter's tibia, and he got a stress fracture in it, and he'd been seeing all sorts of people for a stress fracture, and they eventually asked, could anything be done to try and do anything about it? So he's got a stress fracture because he has a stress riser, because he has high strain in an environment where you're trying to get a fracture to heal. So we looked at it as closely as we could, found where the fracture line was, and put in screws. And honestly, you couldn't be sure that you put them in the right bloody place because you couldn't see the line. But then post-operatively, you could see this sequence. So after a few weeks, he developed that, and it went to that, and it went to that, and his pain went away. So it was interesting. He'd got because his bone was so iron hard, he'd got a stress concentrator, I presume, that was just not allowing the low enough strain for it to bridge, and came across it. Yeah, I was flicked through these ones. Lady had it fixed elsewhere, fell apart. It was fixed again. That's plan B being the same as plan A. Didn't heal. Had it fixed again with a frame, and she went on for some time. And eventually, she still had a non-union, and eventually put in local stabilization, which other people can do with wires. And it's the same sort of thing. I think you've done that, where you just put opposing olives, and you can pull them. And it's exactly the same thing. If you want to control a local environment, then control it locally if that's going to be safe. And depends on the orientation as to whether putting opposed olives through there is more convenient than putting two screws. I don't think it matters what you put there, but you're stopping the shear in that environment. And she'd gone on for ages waiting for the mechanics to be right. And my last, I like this one. So this was a long time ago. So you can see that it's an old-fashioned nail. So inadequate stability, non-union, and this was the first locking plate that was put on in Oxford. A colleague of mine put that on. Looks really nice, actually, except it's a bit not straight as it could be. But she did very well. She was a lady in her 80s, and she was actually discharged because it looked like it had healed fine. And then she came back with that because it hadn't healed as much as it might have done. So the mechanics were clearly wrong now. So she had a frame put on it, and you can see the hinges on it. We straightened it out, and it was great. She did well. She kept mobile, no problem at all. Took the frame off, and she broke through one of the pin sites a little bit further down the leg. Now, this is where plan B or plan C can be the same as plan A. This is a much better fracture to nail now because it's much further down the bone. So we nailed it, and she went back to plan A. So non-unions, restore the mechanics, but look at the totality of the patient to see where they're going. I don't like the traditional definitions. I sort of have that in my mind. That's going to dictate the timing when you think that you don't want it to be a bigger problem than it needs to be. If you can do something as a day case that is going to resolve the problem, do it that way. And it's a lot cheaper, as Alex's paper on this shows. It saves a lot of money. And I've excluded those things. And those are a couple of references. I think it's lunchtime now. Thank you very much.